Hi there. This week we're going to provide an epidemiological perspective on the very fascinating but extremely challenging area of psychiatric comorbidity and substance use disorders. Comorbidity is a term that's been used for many years. It's evolved in different ways. It's sometimes called co-occurring disorders. Regardless of what you call it, it means that two disorders or illnesses occur in the same person, either simultaneously or sequentially. And comorbidity implies that the interactions between the illness that these interactions affect the course of both illnesses. So within psychiatry, comorbidity is commonly used to refer to the overlap of two or more psychiatric disorders, even though we know that many medical conditions overlap as well. The interest has been in the overlap with psychiatric disorders and substance use disorders because they just suggest all kinds of important hypotheses about causal mechanism. And for that reason, comorbidity between substance use disorders and mental disorders has gained increasing research attention, particularly in the last 20 years or so, especially with the development of structured and semi-structured psychiatric interviews, which makes it a lot easier to get accurate, reliable diagnoses of substance use disorders on the one hand and psychiatric conditions on the other. So how common are comorbid drug abuse and mental disorders? Well, for drug abuse, patients with mood or anxiety disorders are about twice as likely to also suffer from a drug disorder. And patients with a drug disorder are roughly twice as likely to be diagnosed with a mood or anxiety disorder. And the same relationships exist with alcohol use disorders. The rates of specific comorbidities also vary by gender and by the particular condition. So comorbidity is elevated, but not extremely so with regard to psychotic disorders, but it is very elevated with regard to affective disorders and anxiety disorders and personality disorders. Why do substance use disorders and other psychiatric conditions co-occur? Well, we're going to go into detail about this in the next few lectures, and certainly it's covered in your readings. But to get us started, there are a variety of different hypotheses that we can consider, and many of them are only partially right. For example, overlapping genetic vulnerabilities. Predisposing genetic factors may make a person more susceptible to both addiction and other mental disorders. And that implies that maybe one isn't causing the other, but they both have some common factor in the background, which makes a person more susceptible to both. We may find a high correlation because of overlapping environmental triggers like stress and trauma and early exposure to drugs and a deprived environmental setting. All of these common factors may increase the chances of medical conditions, psychiatric conditions, and substance use disorders. There may be something to do at the level of genetics and neurobiology with regard to how neurotransmitters function and influence behavior. So brain systems that respond to reward and to stress may precipitate people to use drugs when those brain systems also lead to feelings of anxiety or depression. And finally, drug use disorders and other mental disorders are developmental disorders. That means that alcohol and drug use disorders often develop during mid to late adolescence or early adulthood. And that's about the same time that many psychiatric conditions tend to manifest themselves most frequently. So that comorbidity may be a function of developmental history. Late adolescence is a particularly stressful and vulnerable period, and it may make somebody susceptible to both alcohol, drug, and psychiatric disorders. What are the psychiatric conditions most associated with alcohol and drug use disorders? Well, as you might expect, the major categories are transient states related to alcohol and drug withdrawal, so anxiety, depression in particular, and beyond the withdrawal symptom disorders are psychotic disorders, mood or affective disorders, anxiety disorders, in the case of alcohol, pathological jealousy. Suicidality is elevated, the tendency to think and act with regard to suicidal behavior. Personality disorders are very important and are often neglected in explaining this correspondence between substance use and psychiatric condition, but in particular, externalizing disorders, personality disorders that affect a person's behavior are highly correlated with substance use disorders as well as other psychiatric conditions. And finally, organic brain syndromes, as you might expect, dementia in particular, are related to substance abuse. So why do we study comorbidity? Well, it seems obvious. Comorbidity potentially has implication for theories of etiology, also for the design of prevention and treatment programs, as well as service planning. So if we can get a better idea, not only of the prevalence of these disorders as comorbidities, but also their etiology, we can perhaps do a better job in our prevention and treatment programs. The relationships between substance use and mental disorders are rather complex, and there are a variety of different mechanisms that can be invoked to explain the high rates of comorbidity. One is correlational. Basically, we know there is a statistical association, but that does not prove causality. And as we will see, we need better etiological theories and better etiological research, including epidemiological studies that often follow cohorts over time to document when substance use disorders begin and when mental disorders begin, how they're sequenced, and how one might exacerbate the other. So even though mental disorders are often assumed to cause drinking and drug use, and psychiatric conditions are often assumed to cause substance use, and substance abuse is expected to cause psychiatric conditions, it is quite possible that there are two causal mechanisms that operate in parallel, and both of these theories may be accurate. And it's quite possible that correlation exists as well, where many psychiatric conditions may be totally independent of substance abuse, but they just happen to co-occur for no other reasons than statistical association. Finally, it becomes difficult to study the sequencing, the phenomenology, and the causal mechanisms, in part because we're relying on self-report information, and people sometimes retrospectively attribute either substance abuse to their mental illness symptoms, or they attribute psychiatric symptoms to their substance abuse, in which case the meaningfulness of this for an individual may play a role in the future in the comorbidity itself. Not only the way they report it, but also they may believe that the use of alcohol, for example, relieves depression. And that belief may lead them to increase their substance use beyond what they would do if they didn't have that belief. A big conceptual issue in studying comorbidity is this notion of primary and secondary disorders. So with the advent of structured and semi-structured psychiatric interviews, it becomes possible to ask people retrospectively to reconstruct the symptoms that they've experienced during their lifetime for both substance use and for psychiatric symptoms. And when we ask those questions, we can ask people to think about a period when they had symptoms, for example, of depression. And then we can have them age date the period when they experienced those symptoms, and we can ask them other questions about whether they were using any substances. And if so, whether the substance use amounted to a diagnosis of a clinical syndrome. Similarly, whether the depression symptoms amounted to a diagnosis. And in both cases, we can date the onset of the symptoms and the onset of the syndromes. Once we've done that, we can start developing a chronology in large numbers of patients in order to find out which disorders antecede which other disorders. And that allows us to determine which disorder is primary. If depression comes first and then substance abuse, then depression is primary. If people started using a substance and they later developed an anxiety disorder, then the substance use disorder is primary. In both cases, there would be comorbidity at some point, but it may be beneficial to know which one came first and whether there's a pattern in a large proportion of patients or people in the general population that suggests that one disorder precedes the other. Another issue is whether the disorders are independent versus induced by substances. In the case of alcohol and drugs, we know that they're associated with anxiety and depression, in part because these are frequent symptoms that people experience when they undergo withdrawal. And when they're chronically using a substance, they then are characterized as substance-induced psychiatric disorders, as opposed to a disorder that developed independent before the onset of substance abuse and later substance abuse developed. So we've got to sort out whether the disorders, the psychiatric disorders, are induced by substance use or are independent. And finally, some of these syndromes are so interconnected that all the symptoms are occurring at the same time, that maybe it would be better to have a global diagnosis rather than trying to identify syndromes which in many cases are confounded with symptoms of other syndromes as well. So in a typical diagnosis of substance use disorders, anxiety and depression are frequently prominent, And maybe it would be better to come up with some sort of a syndrome that is broadly defined as psychiatric and substance abuse comorbidity in order to characterize patients for treatment purposes. Again, what we're looking for not only is to understand the causes, but try to figure out ways of identifying patients who may be amenable to particular types of interventions. There are a number of different methodological approaches that can be used to study psychiatric comorbidity. Genetic epidemiology has been very helpful in allowing us to see whether these disorders co-occur in the same individuals with the same genetic background, or whether when there are genetic variations like zygotic and dizygotic twins, we can try to sort out the influence of environment versus heredity. Psychiatric epidemiology surveys have been very useful in helping us, as I mentioned, to develop a chronology of different disorders that meet criteria for a psychiatric diagnosis. There has also been a history of laboratory studies where human volunteers are administered cocaine or opioids or marijuana or heavy doses of alcohol, and their mood and other behaviors can be monitored both in acute intoxication situations as well as over time. And finally, we get a lot of useful information from clinical studies of patients in treatment, where we can do assessments of their psychiatric history. Probably the best way to sort out causal mechanisms is through prospective follow-up studies of treated alcoholics and people with drug dependence, following them over a long period of time to find out what their symptomatology is, both when they're using substances and when they're abstinent. And that has contributed a lot to our understanding of comorbidity. The best way that we have in contemporary times of studying psychiatric comorbidity is through the specialized psychiatric epidemiology interviews. Starting in the 1980s with the epidemiological catchment area study and the diagnostic interview schedule, we were able to develop highly structured questions that allowed patients to describe their symptoms for major syndromes. And out of that came improvements in our psychiatric interviews. And about 20 years ago, the National Co-morbidity Study was initiated in the United States to track large numbers of patients in cross-sectional surveys as well as longitudinal follow-up interview studies over time. Out of that came what is called the World Mental Health Survey, which incorporated the psychiatric interview into national surveys that have been conducted in, by now, 30 or 40 countries. And within the U.S. as well, we have the National Survey of Drug Use and Health, which is conducted every year, and it allows us to incorporate new measures every year of different topics of interest, including psychiatric comorbidity. For the National Comorbidity Study, or the NCS, it started in 1990s with the first nationally representative mental health survey. In 2001 and 2002, patients were surveyed again, and there was a re-interview of patients in order to do follow-up evaluations to find out if what the incidence rates were. There were add-ons like an adolescent survey that allowed us to look at young people the symptoms they're reporting. And as this project grew, it also was adopted by other countries. So now we have the potential for comparing population estimates made with the same interview with representative samples of the adult population in 30 or 40 countries around the world. The results of the National Co-morbidity study have been described in hundreds of published reports. But some of the most fascinating findings to emerge from this study are the following. First of all, mental disorders have onsets early in life. Most mental disorders occur in late teens and the early 20s. If we can get people through that highly stressful and vulnerable period, they seem to be much better adapted to dealing with life as opposed to having the development of either a substance use disorder or another psychiatric disorder in their late teens. And the prevalence rates during that period are the highest than at any other period in a person's life. Comorbidity with alcohol use disorders is widespread in the general population. For example, 52% of people with alcohol use disorder had a lifetime mental disorder. And 59% of people with a lifetime drug disorder had a lifetime mental disorder. That means that psychiatric conditions and mental and substance use disorders are highly comorbid, and it requires a lot of attention to figure out what is causing this comorbidity. And that's what we'll be talking about in the next two lectures.